Thank you very much for giving me an opportunity to present this data. So the background, as we know, the considerable number of patients require primary or redo congenital heart surgery in adulthood. Improved life expectancy in congenital heart disease is accompanied by the development of atrial tachyarrhythmia and atrial fibrillation. Atrial tachyarrhythmia occur at a relatively young age and show rapid progression. This slide shows the reoperation rates and estimated prevalence of arrhythmia in adult congenital heart disease. As you can imagine, Eberstein, single ventricle, tetralogy fallow, atrial switch for the transposition of great arteries, congenitally corrected transposition, and truncus arteriosus carry a high risk for atrial arrhythmia, ranging from 15 to 60%. But this is quite reasonable considering the fact that these conditions require considerable numbers of reoperation for residual regions. It is interesting to note that atrial septal defect is a simple procedure with a low risk of reoperation, but carries a relatively high risk for the atrial arrhythmia. As we know, fontan patients, especially having atrial pulmonary fontan, carry a high risk for atrial arrhythmia. Significant atrial arrhythmias occur at least 50% of patients during the long-term follow-up. Short-term recurrence rates after catheter ablation for single ventricle patients greater than 50%. These factors contributing to the disappointing results of catheter approach include chronic atrial hypertension and dilatation, distorted anatomy, multiple reentrant circuits, restricted catheter access, particularly following lateral tunnel type repairs, and the inability to deliver the ablation regions of sufficient depth of create a line of block. So most of atrial pulmonary fontan patients with a disabling atrial arrhythmias have significant hemodynamic abnormalities, including obstruction of the right atrium to pulmonary artery connection, pulmonary venous obstruction, and massive dilated right atria with sluggish venous flow, predisposing to atrial thrombosis. These are the papers from a Chicago group that probably everyone knows. They reported the importance of concomitant arrhythmia surgery at TCPC conversion. In this paper published in the JTCVS in 2001, they have done arrhythmia surgery in 40 patients. They initially used the technique of isthmus block, then changed to the strategy to the use of modified right side maze. Overall arrhythmia recurrence was 12% and only 10% of patients receiving anti-arrhythmia medication for long term. Actually, these patients are the first 8 patients, and they concluded that importance of the use of modified right side maze rather than isthmus block only. This is a recommendation from the guideline. Class 1 includes a modified right atrial maze procedure in adult undergoing fontan conversion with a symptomatic right atrial reentrant tachycardia, and a modified right atrial maze procedure in addition to the left atrial Cox maze 3 procedure in patients undergoing fontan conversion with a documented atrial fibrillation. However, atrial arrhythmia surgery in other forms of ACHD are not well discussed in the guideline. I just want to show you the arrhythmia surgery technique. This slide shows the Cox maze 3 and modified right atrial maze. On the left side handed panel, you can see the dotted line for the incisions, and the star lines show the clear ablations. The right-sided cartoon shows the right-sided atrial maze, which consists of the dotted line to the ASD, to the right atriotomy, and also isthmus block is included. So the modified right atrial maze is designed to interrupt critical areas re-entry specific to the Fontan patients, which is the atriotomy scar, rim of atrial septal defect, and lateral right atrial wall, the right atrial isthmus, and priori atrial pulmonary connection. This is systematic review and meta-analysis from Journal of American Heart Association in 2020. This review covers 28 studies looking at atrial arrhythmia surgery and congenital heart disease, and I would like to show the summary of this study. Biatrial arrhythmia surgery is used for the patient with atrial fibrillation. The lesions are Cox-Maze 3 or 4 and its modifications. Overall recurrence is 13%, but ranging from 0 to 78%. But in a case having more than 20 cases, the recurrence is 20% during follow-up of 1 to 7.4 years. The study from Japan showed no difference in the recurrence rate between a patient with a paroxysmal atrial fibrillation and non-paroxysmal atrial fibrillation. Presence of congenital heart disease did not appear to influence the recurrence. For right-sided arrhythmia surgery, most surgeons use a modification of Cox-Maze 3. Others use a right atrial compartment or just isolation technique, which generally consists of a single incision parallel to the sulcus terminalis, extending posteriorly and anteriorly towards the tricuspid valve annulus, including cryo lesions between the incisions and tricuspid valve. The study showed the recurrence is below 30%, ranging from 7 to 29%. So what about the comparison of right-sided maze versus cryoablation of the isthmus? So the recurrence rate is comparable in the Epstein disease, and the recurrence more often when the indication is atrial fibrillation rather than micro re-entrant tachycardia, and also indication is non-paroxysmal atrial fibrillation rather than the paroxysmal atrial fibrillation. So comparison of biatrial versus right-sided arrhythmia surgery, exclusive right-sided lesions appear to be less effective than biatrial lesions in the treatment of atrial fibrillation in the atrial septal defect. Exclusive right-sided lesions appear to be less effective than the biatrial lesions in the treatment of non-paroxysmal atrial fibrillation or micro re-entrant tachycardia. So performing biatrial arrhythmia surgery for the atrial fibrillation, regardless of duration or long-standing atrial tachycardia, and patient with a right-sided congenital heart disease. For the left-sided arrhythmia surgery, in this review, only 5 studies done for the exclusive left-sided arrhythmia surgery, and none of these studies show solid indications. How about the prophylactic arrhythmia surgery? This review showed 5 studies looking at outcomes. As you can see, the outcomes encourage us to perform prophylactic surgery, but it is important to note that although prophylactic arrhythmia surgery is effective when a bidirectional block achieved, this may be pro-arrhythmogenic in the absence of bidirectional block. When looking at atrial septal defect, the most study used biatrial lesions. Comparison of biatrial versus right-sided lesions is more effective in the ASD with atrial fibrillation. The recurrence of biatrial surgery is about 5% compared to the 40% of right-sided lesions. Concomitant arrhythmia surgery adds benefits of less post-operative atrial fibrillation. Study from Japan showed in 26 patients with atrial septal defect with atrial fibrillation had arrhythmia surgery. As a result, 12% had a persistent atrial fibrillation. but no patients had a recurrence when a sinus risen after the surgery. The most important finding of this study is that 18% had atrial fibrillation occur if only atrial septal defect is closed, even no history of atrial fibrillation. Another study looking at effect of concomitant arrhythmia surgery and post-operative atrial fibrillation was significantly higher in patients having ASD repair only when compared to the patients having concomitant arrhythmia surgery. For the Epstein disease, the risk of atrial tachyarrhythmia is because of due to severely enlarged right atrium. There are two studies from the Mayo Clinic. One is from 2004, including 48 patients with right-sided lesions, including MACE 38 and isthmus block 10. The outcome was recurrent atrial tachyarrhythmia was 25% at 2.8 years. The study from 2006 showed 86 patients with right-sided and biatrial arrhythmia surgery, and now recurrent of atrial tachyarrhythmia was only 9% at 4.5 years. So they concluded that biatrial region is more effective in the treatment of paroxysmal atrial tachyarrhythmia in the Epstein disease. For the tetralogy of flow, this is a study from 2006 looking at 249 patients undergoing reoperation. About 16% of patients had atrial tachyarrhythmia preoperatively, and 34 had right-sided lesions, including isthmus block in 22 patients and MACE procedure in 12 patients. So the recurrence was about 25% compared to the 66% in no arrhythmia surgery. So again, the advantage of arrhythmia surgery in the documented pre-op arrhythmia in the tetralogy follow. So this slide shows the factors associated with atrial arrhythmia recurrence. So independent predictors of arrhythmia recurrence included older age at the time of surgery and preoperative atrial arrhythmia duration over 3 years. One study analyzed factors associated with the time to event, which was decreased in patients undergoing right-sided MACE procedure versus biatrial arrhythmia surgery, and those with a significant preoperative tricuspid regurgitation. How about new onset atrial tachyarrhythmia after the arrhythmia surgery? This may be a result of incomplete regions. The study from 2013 showed new onset atrial tachyarrhythmia higher in patients having arrhythmia surgery versus those without. And another study showed prophylactic cryo lesions between the arrhythmia and tricuspid valve annulus. New onset atrial flutter in patient without bidirectional block. So incomplete lesions are potential cause of new onset atrial tachyarrhythmia after the arrhythmia surgery. So I'd like to show the permanent pacemaker implantation because this is very important when we do arrhythmia surgery. In this review, 20 studies reported and requirement of pacemaker implantation was about 10%, but ranging from 0 to 42%. Actually, 13 studies having more than 20 cases, the requirement was 15%. In summary, the modified right atrial MACE procedure is indicated in adults undergoing Fontan conversion with a symptomatic right atrial intra-atrial re-entrant tachycardia. A modified right atrial MACE procedure in addition to the left atrial Cox MACE 3 procedure is indicated in patients undergoing Fontan conversion with a documented atrial fibrillation. Biatrial regions rather than an exclusive right-sided region is preferred in congenital heart disease with paroxysmal or non-paroxysmal atrial fibrillation. Patients with ASD and a history of atrial fibrillation, regardless of non or paroxysmal, appear to benefit from concomitant biatrial arrhythmia surgery during ASD repair. Right-sided maze procedure is likely the most appropriate treatment of micro-reentrant tachycardia without documented atrial fibrillation, as no evidence for the superiority of biatrial regions. There is not enough data to support to use exclusive left-sided lesions in patients with congenital heart disease. And congenital heart disease specific outcomes were not provided for the ASD, Epstein, and tetralogy Fallot, but it may be reasonable to assume that conclusion states above also apply to these regions, as they are associated with a predominantly right-sided disease. Thank you very much for your attention.